Hi everyone, welcome. This particular lecture is a discussion of central lines. Compliments to the two ID nurse specialists that helped put this together. They're listed here on the front, and these are two nurses that's their expertise. This is literally what they do. They manage these kind of lines in the hospital. They may insert PICC lines and discontinue them. And the idea of this lecture is to give you an overview. I know you've probably seen them in the hospital setting. You may have heard of bits and pieces of it in a lecture, but this is an overview. I know you had ID lectures where we kind of introduce the concept of central lines, and this is hopefully to sort of pull it all together for you guys a bit. The objectives of this course is to identify the different central lines typically in use, and understand the uses and limitations of the various types of ID access, and identify common complications of central lines, as well as the prevention of central line infections and or the occlusion of such lines. Now, just as a description, you'll see central line, persons say the word central line. They may say the CVC line, meaning central venous catheter. But by definition, it's an intravenous access placed in the central vascular for either short or long-term use, depending on the catheter used, and it's often called a central line. Now, there are typical insertion sites you'll see on patients for central lines. Central entry, it could be tunneled or non-tunneled. So, non-tunneled is like the groin side of the neck, the subclavian. They know the vessel's right there, and we're injecting the needle to go right into the vessel, right over the vessel, then through the skin and the subcutaneous tissue into the vessel. Tunneled is an attempt to limit the risk for infections, knowing you're going to have it longer. They might go a couple inches away, tunnel under the skin to get into the vessel. So you want the insertion site further away from the vessel to attempt to minimize infections. The subclavian vein is a common access site, and the internal external jugular, as well as the femoral vein. Peripheral entry also occurs more distally. Typically, the cephalic or the bacillus vein are most popular. Now, where does the tip terminate? So just because I see it in the femoral site, or I see it in the jugular and the subclavian, doesn't necessarily tell us the length of the actual catheter that you're using. Superior vena cava is a typical location if it's a central line, a true central line catheter. The best location is right at the atrial junction. We'll show you a picture of that in a few minutes. Inferior vena cava occurs if the catheter is placed in the femoral vein. So you're coming from another direction. Remember, inferior and superior vena cava come together to the right atrium. Subclavian is no longer desirable. You will see that location as well. But it has a higher incidence of complications. And only an X-ray can verify the tip location. So you may come in on a patient, you have to check the orders and the chart to actually know what kind of line it is. You don't necessarily know that for sure from the external view, although you do on some days, you'll know. Okay, so let's start talking about some of the different catheters. Now, there are midline catheters. This can be a little confusing for the nurse at the bedside because externally it could look the same as a PICC line because they look similar in the dressing and the location externally. But a midline catheter is generally 3 to 8 inches long. It goes in through ultrasound guidance, so this regular staff nurse is not putting this in. This would be in a specialty area, an IV specialty nurse. You'll need ultrasound guidance to find those deeper veins, and it doesn't go past the axilla. You can see in the picture here, it's up in this location, whereas a central line, we'll show you a picture in a minute, would go to the superior vena cava. Typically, these are chosen. You need some sort of therapeutic use of IV medications 1 to 4 weeks, not long term, and not necessarily short term either. Into the upper arm, placed at the bedside for short term use. may not be, you cannot draw lab works from this catheter. So you'll see nurses drawing from some lines and not others. Blood pressure and lab draws may also not be done on the arm affected. So when you see this kind of dressing, question what kind of line it is. And if it's not a peripheral line, it's a midline or central catheter, generally you don't do blood pressure, you don't draw IVs. Remove it at the bedside by the IP nurse or as per hospital policy. So if somebody says go remove that PIC line or that midline catheter, you need to go look up the policy. Because it's possible sometimes the nurse isn't comfortable with it, she dumps it on you and the teacher. Depending where you work, that's only withdrawn by the specialty nurse. And then there's PIC lines. These are fairly common. They're peripherally inserted central catheters. You'll see them called a PIC line. You need to be careful in the chart that people aren't starting to call a midline catheter a PIC line. It's a different location. Nurses who insert these have specialty training. The length is closer to 18 to 29 inches, so it's a longer line as compared to the midline catheter. And you can see in the picture here, this one goes to the superior vena cava. It's made it past the arch, so it's considered a central line. It's basically, the basilar vein is a preferred location, and the tip is generally, like I said, in the superior vena cava. If it's a purple port, in most brands, most institutions, that's called a power PIC line, and it can be used for tests, like if they're going to do angiography pictures for CT or MRI. Not all PIC lines can you also use them in those procedures. It's placed by the RN with a specialty training, and it's removed at the bedside by the IV nurse, the IV specialist. Now again, that depends on the institution you're in, and you need to look at their policy, but a lot of places, the IV nurse manages these lines. Short-term use, or it could be used for months. Blood pressures and lab draws may not be done in the arm that is affected, which is the same as the mid-length line, so it should be easy to remember. Now there's the percutaneous inserted catheter lines. These are central lines, but they're not, you can see, they're not out in the arm. We've got a neck here. Okay, you can see the lower right-hand corner. We'll talk about that in another lecture, but that's a Swan-Ganz catheter. It's a central line. You can see the white port near the neck has a side port with a little blood in it coming off. That's the cordis introducer. So that line was put in with a needle in it, as you see in the upper picture here, upon initial insertion. Then the yellow line coming out of that has a rubber stopper in it, and they funnel that long yellow line through there. These are for short-term use. Insertion is by direct skin puncture into a vein with a steel needle. So I've got the plastic soft catheter. As you can see, it's curved, it's soft in the right picture over there with the triple lumen coming off of it. Okay, and then, but a stiff needle goes into it, steel needle into it. The catheter is threaded over the needle and cannulated into the vessel. Okay, so you punch the vessel. Once you get through, you can keep the needle there with slowly withdraw the needle as you're funneling the catheter in, just like when you start a peripheral line. You know how you get it on the needle, then you get the catheter off and the needle comes out and the catheter slides in. Now, so what's the advantages of this? These are fairly common in intensive care setting. You can use them for multiple medications at once. You can see this one here, the picture to the right has a triple lumen, so it has 3 ports. One's an 18 gauge, 2 18s and a 14, I think. I can't remember off the top of my head. They're large bore. When you go in, look at them. When you see one on a patient, look closely at the hub, and it'll tell you how many what size catheters they are. What's the beauty of that is you can give blood products. You can give more sclerotic type things that might irritate a peripheral vessel severely. You can give those straight into that line. And you can give multiple meds at once. This is a wonderful tool. It can be placed quickly at the bedside. Literally, you're setting up a sterile field, open the sterile kit. You're creating a little mini surgery suite, doing everything like I showed you in the mock code, that list of things to do when you're setting up a procedure. And they can actually be done fairly rapidly. And you can give non-compatible medications at the same time. So when you have this catheter, it has, when you look at the triple lumen, it's about this long, and it has a hole at the tip, a hole a couple inches further up, and a hole a couple inches further up. So each one of those holes is for one of those IV ports. So theoretically, the medications aren't mixing. So you could give things that aren't considered compatible through the same line. And it's a big vessel, so you can give multiple meds at once. You're not going to blow the vessel like you would on a little teeny peripheral vein. And you can draw lab works. So huge advantage, this puppy. Disadvantages, certainly it's separating the periphery into a major vessel, a greater risk for infection, and certainly they're not for long-term use. They're not as comfortable as the long-term catheters, which we'll go over some of those. These are not tunneled catheters. You can see in the picture, it's percutaneously going right into the vessel. Not for home use. You won't see people going home with this particular catheter. A little bit more about the triple lumen. Here's another picture here showing it. It could be, when you open the kit, it could be a single, double, or triple, or quadruple catheter. Most of the time, you're going to see a triple lumen being put in. They're made of polyurethane, placed at the bedside, could be done in the cath lab or interventional procedure room or the operating room. May be found in the neck, chest, or groin, so jugular, subclavian, or femoral. Femoral is very popular in children. And removed by the ICU nurse or the IV nurse. Again, depending where you work. Most places I've ever been, the ICU nurse discontinues them at the bedside. And they are meant for short-term use. And we said that's large bore, so you can infuse blood products and multiple medications at once, which is wonderful. Then there are tunneled catheters, which could be the same kind of catheter. Tunneled is referring to how it's going in. Okay? You can see in the picture here where the exit site is not necessarily where the vessel's at. So normally it would go right here, right into the vessel, but instead they came further out, so it's tunneled under the tissue, then into the vessel. This is meant for more long-term use when you're worried about infections because it's going to be there longer. It's a silicone catheter, tunneled from intrasite under the subcutaneous layer, about 2 to 12 inches away, but gets into the central vessel. Typically not at the bedside. This would be an interventional or operating room procedure. Tubing, maybe, because you're typically putting this on purpose for long-term use. What you see in the ICU is short-term, we're in a hurry, they're going to go straight into the vessel. Tubing may be made to chemically bind to heparin. So again, it has some preventive embedding into it because it's sought to be for long-term use. Okay, and here's just another picture of port placement. You can see where the collarbone's at, and you can see where the point where the central line enters the body, but the vessel is further away. So literally it's done tunneled under the tissue to protect it for a while. Then you can see the connection there. Actually, a little arrow. So here's an insertion site, but yet here's a vessel up here. And then it's taped and dressed on the outside externally. Okay, so what's the advantages of tunnel catheters? Well, lower incidence of infection than the percutaneous placed catheters. You're not right directly over the vessel, and short to for bugs to get to the vessel. It's generally more comfortable, and with ports, the ports are not visible. So if I had a jugular right here and I was going to the grocery store, I have this thing hanging out, right? Which you obviously don't see. This could be under the clothing, so it's more marketable community-wise, unless, of course, it's in use and there's something hanging into it. May be used for extended period of time, so they're for longer-term use. Requires physician for placement and removal. So it's not a casual thing that's removed in the ICU. So there's always disadvantages. That of the tunnel catheters is required patient to go to interventional or operating room for replacement. It can't be done quickly and easily. And it's more expensive. They also, one of the advantages, it's coated with antibiotics. So again, to help protect it over time, since it's going to be kept in longer. Okay, so those are tunnel, those are percutaneous, but they're also port lines. You may or may not have seen those. If any had a rotational oncology floor, you've probably seen these. They can be chest or arm ports. Now, the guidelines I'm giving you here may vary depending on the institution, but this is a general overview for you. And you can see in the picture up here in the corner, that's what they call a hover needle. You need a special kind of needle to insert. So this silver thing you're seeing here, right here, would be under the skin, and here's several examples of them here. And this is a needle that would be on the outside. Sometimes it looks like a squared off needle, or that one with a pad. So you're injecting just through the skin into it. It's made of silicone and attached reservoir. Placed in an interventional or operating room, removed only by the physician. Long-term use could be for many years. Usually these are for chemo patients because they'll have chemotherapy and then nothing for a long period of time, and then chemotherapy again. Chemotherapy obviously is very sclerosing to the veins. You can't eat up all your peripheral veins. These ports are incredibly useful for that population. It's not a power port. It can not handle high pressure, so you use the 10 milliliter syringe or larger. So power ports, I don't know if you realize that, but in the like places where they're doing angiograph, you push the dye at high pressure rapidly for the pictures. Not all ports can handle that. So that would be a power port if it could handle it, which is the purple port I talked about earlier. So newer power ports will allow for use for CT and MRI if you're doing those kind of pictures, but you'd have to know that you have that type in. Must be accessed and flushed with heparin every 30 days when not in use. So generally there's a little bit of some sort of treatment for long-term management. The big advantage is not outside tubing when not in use. So literally it can last for ages, which is hugely beneficial for some of these patients. And here's a picture you can see under the skin on this particular patient of a chest port. They could be single or double. I think if I showed you the picture a minute ago here, you can see a double and a single examples. Single is most of what you're going to see. Accessed by IV therapy at the bedside with a non-coring needle, which is the funny needle I showed you in the picture before. So it's not meant to puncture through things, just through the skin. Sometimes you'll come out on a patient and you are using this in the hospital, and they'll have it bored with the specialty needle, and you're just connecting the little connector on the outside. You might be changing the IV bag or whatever. Can be used as a lump, can be seen as a lump under the skin in the upper chest. Now there's complications. Specific to a port, it flips underneath the skin of the port. It's possible, and then of course you can't access it because you're just banging on the sterling on the silver or the stainless steel on the bottom side. It can dislodge and the needle resulting in an infiltration and the pain of a needle access. Certainly you're puncturing through the skin occasionally when you do go in. Every 7 days or so as needed if you're changing out the port or whatever you're doing. So you're still getting stuck, whereas like a PICC line, the patient is just a plastic that gets stuck. Definitely useful for long-term use. And you'll, again, see these probably most likely on the oncology floors. Here's another picture showing how it would be under the skin. The catheter's going into the vessel. You can see you've got some subcutaneous tissue, and you're just going through there into the metal and silicone catheter port, actually. And here's another picture of an arm port. So sometimes these are periphery out in the arm, placed in the upper arm and may be seen as a lump on the inside of the arm, either just above or below the antecubital space. Tourniquet may not be placed on that arm, so no blood pressure is also on that arm. So we're careful to find out what kind of IV access our patient has. Complications specific to arm ports are they're difficult and painful to access. Thrombi in the arm, you can end up with a clot, often overlooked as they are small and not easily seen by an untrained eye. So you can have a patient coming in very sick and not realize it's there and start doing blood pressures on that arm. I don't see these as common. The upper ports are more popular. Okay, now a Hickman catheter. Here's yet another line to learn about. It's a long-term tunnel catheter placed in the chest. Here's a picture over here of an undressed Hickman. It's placed in the operating room or interventional, used for cancer patients, for not as long-term, but certainly a nice central line. It can handle high pressure, so always use a 10 milliliter. Cannot handle. So back up. If I have a feeding tube, like a feeding tube, and I'm trying to inject, medications, if I'm having trouble, I feel like it's clogged up, one of the things we do to get it unclogged is put a 1 cc syringe, because you're more likely to get that through because it's a higher pressure. But it's dangerous on something you don't want to rupture, to use that same physics idea or technique. So it cannot handle high pressure, so always use a larger syringe to flush the line. If it's purple, it is a powered Hickman and may be used for tests. Long term is the idea of putting a Hickman in, up to and beyond 12 months. Some patient may have this in. Certainly the disadvantage is to always have the lumens on the outside of the body. So this is easier to put in, certainly, than the one under the skin. So you're making an estimate on how long you need it and the long-term use for the patient, what you might put in. And here's just another picture of the Hickman catheter cannulated in a vessel. You can see it would be tunneled under. It's just a different type of catheter. Then, of course, you have dialysis central lines. Not be confused with all the other central lines we just went over. Again, you need to know, look in the chart and know what kind of catheter, what is it that you're looking at. These are generally for short-term dialysis or apheresis catheters. Are made of a stiffer plastic, and you can feel them, it's kind of big and they're stiff, a polyurethane. Dialysis catheters usually have at least 2 lumens attached to 2 ports. Usually there's a blue and a red one. And they obviously just color that way, so you have a venous and arterial is the idea. Generally it's maintained with heparin as well. These catheters are larger in bore for greater blood volume to easily flow. So this is meant for dialysis. Removed by physician. If it's an arm, you may not do blood pressures or venipunctures on the affected arm. Most of the time you'll see it where this one's at, like in the general subclavian or jugular area, because they want to save the arm for dialysis fistulas. Not used for IV or blood draws. So you may have this patient and you're going crazy trying to start IVs, and you've got this beautiful IV catheter here that you're not going to be using for that patient. Usually dedicated to dialysis only. I can think of one time we also used it for IV fluids on a patient. It's just because there was nothing else. We couldn't find anything else on that patient. Otherwise, it's a dedicated line left alone, and the dialysis nurse manages it. Dialysis catheters. There's different brands. Permacath is made of silicone and it's cupped. You see it on the chest, groin, neck or arm area. Placed in the interventional or the operating room and removed by the physician. Looks a lot like a Hickman, but not, but has larger lumens and shorter length. So it's just a different brand. Cannot be accessed for IV or lab draws, just like the Hickman and other dialysis catheters. Unless, again, I had that one patient, physician ordered. If it's in the arm, may not use again for blood pressure or venipunctures. Grishon catheters. Okay, this is just a fun one to say, basically. It's designed to remain shut if no negative pressure or positive pressure. So this is slightly extra expense. Open-ended blood can back up. It can be with a PICC line. It's a particular type. The theory in the Grishon catheters is if it's closed, no blood will back up into the lumen, making it free of heparin. So it's less problematic. Less problematic because you don't have to use heparin, but it's more expensive. Therefore, it's not as common to see used. So it's a nicety, but an expensive nicety. Any of the central lines mentioned may come in the Grishon style, the style where the blood won't back up. And here's just a picture of the physics of it. Basically, negative pressure, like when you're taking a blood pressure. Positive pressure, like when you give medications, so it'll push in, but at rest, it's closed to the bloodstream. So it's somebody came up with a great design. Whether it's used all the time or not will depend on the patient and the physician. Now, power ports are the PIC, can be, not always, PIC, Hickman, and a port may be used for CAT scan or MRI if they're shooting dye and need to take pictures. If the lumen's purple, it's considered a power central venous catheter, CVC. Before power CVC, patients would have to have a peripheral IV for any test that used a power injector machine. These are obviously approved for radiological testing, and they can handle injection pressures that are required for some tests. Patients having nuclear tests may still need a peripheral IV for testing if it's a central line and not a power port. And again, some of these ports have antimicrobial and heparin coatings, which helps reduce the risk of infection and improve longevity of the catheter. So ports will only be a single lumen chest port and will be marked with a tag on the needle to state it's a power port usually, if that's the type of port it is. That's just like a little overview there. Now, types of catheters. More overview. There's the implanted port with chest portacath. It can be open-ended or valved. That would be the Gershon or not. There's arm passports, open-ended or valved. And you can see the external catheters as the tunneled, open-ended or valved, non-tunneled, open-ended or valved, and the PIC can be open-ended or valved. So each of these catheters can be either type, and some of them can be used for dialysis. What else is worth mentioning here? So how to identify, what do you need to know? So the question's asked, I'm walking and I see this thing in this patient. Is it implanted port or an external catheter? Okay. Good. I can see it under the skin versus I see it coming out. Is the external catheter tunneled or not? Some of that you can tell because of location. Is the tip open-ended or valved? Meaning, is it a Gershon? How many ports? How many lumens do I have? Is it a double lumen? It could be a Hickman for dialysis. Is it a triple lumen? Is the catheter designed and intended for dialysis or apheresis? So do I need to set it aside, not use it for anything else? And where does the catheter enter the venous system? Is it going through the groin? Is it going through the jugular? Is it going through the subclavian? And then when I know all that, where's the termination of the tip? So is this, what I'm looking at in the arm here, actually a PIC line or midline catheter? I think that kind of gives you a bit of an overview there. And then, of course, there's always complications. So what are the complications of the central line? Pneumothorax when placed. One of the horrible, my worst scenario, we had a young man, he was a head injury, I think it was a motor vehicle accident, if I remember correctly. I remember he was this big strapping high school football player, the star. And they were putting a central line in him, going through the subclavian, and, well, back up, through the neck. This was the neck. It was a jugular. Nicked the carotid. He coded within seconds. And we were lucky, a vascular surgeon nearby. We had to open his chest and pull out giant clots out of his chest. It was shockingly amazing. It's amazing how well this goes most of the time. This one didn't go well. That's the only time I've ever seen that big of a disaster. Literally had to crack his chest right there in the room. Horrible, because he was just starting to wake up, and it set him back quite a bit. Pneumothorax is relatively common. It's certainly a risk when you're injecting in this area. So after you do put in a central line, you generally would get a chest x-ray, and you want to make sure breathing's even equal on both sides, because the lungs are right there. Certainly infection when in place. This is all done with a sterile procedure. You manage the dressing changes by the hospital protocol very carefully. These are going, you're not just going to have peripheral infection, you could get it into their vascular system. You can end up with an arterial puncture, which I just described in a young man. We had to open his chest. Or malposition of the catheter. It just didn't go where it's supposed to go. Certainly thrombus formation in or around the catheter, a risk for clots is relatively, high risk issue. Bleeding when you move it. I've never personally had problems with the patient, but these are big vessels. You're taking it out. You hold pressure for a while. And certainly venous air embolism when removed, and certainly anytime you push meds into a line, there's a risk for air embolus. Okay, and a little more about thrombus. Causes by restricted blood flow around the catheter or catheter irritation of the vein wall. You're sticking something in a vessel. It's not designed for that. Heparin use inside catheter to deter fibrinogen sheaths from forming. So typically, most of these will have some sort of protocol, depending on your hospital, to maintain the patency of the line. High dose heparin is used inside dialysis catheters. So after dialysis is done, the nurses will inject in the line, in the tubing, leave it in there. Don't flush anything through. They leave it in the tubing, the heparin. Coumadin may be given to patients with a long-term tunnel catheter to minimize the risk. And arm points and PICC lines, it's a high risk from thrombus because you can see it runs a longer length of any given vessel. And certainly it can be infections of central lines. Number one cause of nosocomial infections in the USA are IVs. Short-term catheters more likely to get infected. Now, is that because they're worse catheters? It's quite possibly because those are sicker patients. If we know it's a controlled situation, somebody's going to have chemo treatment, we go into a procedure, the patient's sitting upright and ate well that last 2 weeks, and you put the catheter in, even though it's in there long term, a lot of times a triple lumen catheter is somebody acutely ill in the ICU. So the infection is part of the patient and part of the type of line. So what do we do to prevent infections? You want to keep an eye on their blood sugars. Obviously, sugar is a media for growth, and so nursing does a better job at tuning those, keeping those tight than we did when I first started nursing. Excess necessity of short-term catheter line each day. So, do we still need this central line in? I remember I had a baby. The kids, it's hard because we have the triple lumens in, and in the ICU, but these kids were acutely ill. Once they start getting better, we just take it out of because sometimes you can't get a peripheral line, and you don't want to keep sticking for lab work. So that's your last chance to draw lab work, and then a lot of times you're like, okay, we're not going to look at labs anymore because we're taking out that central line. If possible, it's nice to place a PICC line instead of a triple lumen catheter, and because they can last longer. Do sterile dressing changes every 7 days, and I'm saying this 7 days is a made-up number because it depends on the institution. Or if dressings are coming off or soiled, certainly. But the bottom line is, what's your hospital protocol? That's your responsibility to follow the protocol at that institution. Wipe the claves vigorously with alcohol before and after use. Some hospitals have policies. I remember the liver transplant team at UCLA had this 6 alcohol wipes and 6, or was it 7? Anyway, it didn't matter. Betadine swabs. So you really had to clean every port before you went into it. It was just some weird policy they had. Most places, it's just clean it once. But the point is, clean it. And certainly very good hand washing. We know that's a major way to prevent passing on the bad bugs. Now, protocols vary with hospital. So I'm not going to tell you this is how to dress it, this is how many days, because their protocol might be slightly dissimilar. But in general, dressing changes are about every 5 days. With these long-term lines, a standardized dressing kit, usually have a central line kit, and or the hospital policy. What is their policy? Some places, the IV nurse is the only one that changes it. She goes around on a routine and manages those lines. Some places it's a staff nurse. There's a sterile technique for placement of central venous catheters with a standardized placement kit. Placement of a CVC in areas less likely to get infected. So if the groin is a nasty, sweaty place, but if I have an unstable patient or a pediatric patient, that may be your best choice. But generally, we would choose the jugular over the groin in a given situation. Dialysis assessment, continued need for central line. Dialysis, daily assessment. So this has been here how many days? It's so convenient. We can draw lab work. We can run central lines. So you tend to hold on to it. But for infection reasons, clot reasons, You need to really think, is this important? Okay, I'm hoping that gave you a nice little overview, and since you have this recorded, if you get confused, you can go back and look at it again, and I will see you in class.